Echinocandins are available for past 20 years and they are now drug of choice for most common invasive fungal infection, candidemia, but they are very expensive. So they are limited in use in only developed countries and they have very few toxicities and drug-drug interactions. So they are semi-synthetic lipopeptides. They inhibit 1,3-beta-D-glucan in the cell wall. They are widely distributed except in central nervous system and eyes, and they are also effective against biofilms. They have class C pregnancy risk and resistance against them have emerged in Candida glabrata, which has reached up to 10%. In Candida auris, it is between 3 to 5%. And there's a regional variation in these rates. And breakthrough infection with Candida parapsilosis can occur while using them. So they have fungicidal activity against Candida and fungistatic for Aspergillus, just the reverse of azoles. So they have similar spectrum and potency, and caspofungin has been approved for refractory aspergillosis as well, and all the three drugs can be used for esophageal candidiasis and candidemia. Micafungin is also approved for prophylaxis in immunocompromised patient in hematopoietic stem cell transplant. The only important side effect is histamine-like reaction during IV infusion. So infusion should be given slowly over 1 hour period, and there is no renal or hepatic adjustment required. The echinocandins lack activity against important pathogens like Cryptococcus mucorales, Trichosporon, and Fusarium because they have predominantly beta-1,6-glucan in their cell wall. It's important to note that Trichosporon is increasingly being isolated as fungemia because it is resistant to echinocandins. Then there are new antifungal agents, and the effort is that patient should not need to remain hospitalized to receive these IV antifungal agents, which is a major drawback of echinocandins. And in a recent study, they have shown that hospitalization was prolonged solely to complete IV antifungal treatment by a median of 16 days in 16% of patients. So Rezafungin has been approved by FDA in March 2023, which can be given once weekly IV, and this can be continued up to 4 weeks. And this is approved for invasive candidiasis and invasive aspergillosis and can be given to a patient older than 18 years age. Another drug, Ibrexafungerp, which is an enfumafungin, it is triterpenoid class of beta-1,3-D-glucan synthase inhibitor in cell wall, similar to echinocandins, and it has been made to overcome shortcomings of echinocandins because it is orally available. Then it is active against fluconazole and echinocandin resistant candida mutants due to FKS alterations, and it also shows good activity against cysts of pneumocystis carinii. But at present, it has been approved by FDA in June 2021 for use again for acute or chronic vulvovaginal candidiasis in post-menarche age group. 2 tablets of 150 milligram twice a day, that is total dose of 600 milligram, is approved. Another drug, Olorofim, which is being produced in UK, is waiting for approval because they have asked for more data. It is a novel class orotomide antifungal agent. It inhibits an enzyme involved in pyrimidine biosynthesis, dihydroorotate dehydrogenase. It is orally also available, and it is active only against molds. So this is basically being studied for systemic mold infections, especially for aspergillus, which are drug resistant, and for difficult to treat molds like Fusarium, Lomentospora, Talaromyces, and endemic fungi. It is not active against these many agents, that is Candida, Pneumocystis, Exophiala, and Alternaria and Mucorales. Another agent is Fosmanogepix. It is fast track approval for 7 invasive fungal infections, and it is an inhibitor of fungal GPI biosynthesis by enzyme GWT1. It is also orally available, and it is a potent broad spectrum antifungal activity. Maybe it will replace amphotericin B in future, and it is effective against Candida auris, which is resistant to azoles and echinocandins. So the 7 invasive fungal infections are invasive candidiasis, invasive aspergillosis, cryptococcosis, coccidioidomycosis. In mucormycosis, it shows sensitivity only for few agents like Rhizopus erizus, which is responsible for 70% of mucormycosis. Also against Rhizopus delimar, then Fusarium, Lomentospora, and Pseudosporium. It lacks activity against other mucorales and Candida krusei. It's very important to know that it doesn't act on Candida krusei, which is already resistant to fluconazole. So this is a very nice depiction of this fungal spectrum of these new antifungal agents. So Fosmanogepix has the broad spectrum of activity other than Candida krusei. Then Ibrexafungerp is active against Aspergillus and Candida and endemic fungi, but only approved for vulvovaginal candidiasis. Olorofim is anti-mold antifungal agent. So here Aspergillus and some of the difficult to treat fungi and endemic fungi. Then opilconazole is an inhalational agent, and it is for lung transplant patients. So some of the Aspergillus and Candida species are inhibited, and Rezafungin is again effective for invasive aspergillosis and invasive candidiasis, the two most common, most important invasive fungal infections seen in neutropenic patients. Antifungal drug resistance is a reality now, and there are different drivers for their emergence. In a recently published article, it's very nicely predicted that Candida auris acquired resistance due to it's been healthcare transmission. It's a nosocomial pathogen, leads to outbreaks, and it emerged because of climatic change. It's adaptation to higher temperature of the environment. Then azole resistant Aspergillus fumigatus has emerged because of fungicide use in agriculture. Trichophyton indietini has emerged because of underregulated over-the-counter high-potency corticosteroid use. So the most striking thing is the diversity of fungi themselves and the drivers of their emergence make it clear that we cannot predict what might emerge next. So it's very important to keep oneself abreast with all these information which is coming, and it will be very important with limited antifungal agents available in our hands, which are toxic and costly. So pollens show very rare resistance, and usually after exposure in some of the species of Candida, that is Candida lusitani, Candida glabrata, Candida krusei, Candida auris, Candida guillermondii, and very rarely in Cryptococcus neoformans it has been seen. And primary, that is inherent resistance, is seen in Aspergillus teres. It is because of reduced ergosterol content or masking of ergosterol because of alteration in these ERG genes. In azoles, in Candida, only Candida krusei is inherently resistant to fluconazole. And rest, they show resistance either because of point mutation in ERG11 gene, or there is upregulation of genes coding for efflux pumps. So when major facilitator type efflux pump is involved, then only resistant to fluconazole is seen, and when ABC transporters are involved, then multiple azole resistance is seen in Candida. In Aspergillus fumigatus, it is because of point mutation in CYP51A gene, and this can lead to resistance against 1 or 2 or 3 azoles like itraconazole, voriconazole, or posaconazole. And there is also increased drug efflux in these isolates. In Cryptococcus neoformans, it is a secondary resistance to fluconazole use, which is transient adaptation. In Echinocandins, the resistance seen in Candida glabrata is because of point mutation in FKS1 and FKS2 genes. In flucytosine, it is either decreased uptake or loss of cytosine deaminase activity. And in derminafine, it is CDR1 multi-drug efflux pump responsible for emerging drug resistance. There are a few indications for combination antifungal therapy, otherwise combination should not be used. It is to achieve synergy and avoid antagonism. So in Candida peritonitis, amphotericin B is used with flucytosine to achieve synergy, and in cryptococcal meningitis the combinations are amphotericin B with flucytosine, amphotericin B with fluconazole, or flucytosine with fluconazole. So only at these places combination antifungal agents are used. There are certain drug-bug combinations which should be avoided, and they are like this deoxycholate should be avoided in fusariosis or pheohyphomycosis. Liposomal amphotericin B should be avoided in lomentospora and pseudosporium. Azole should be avoided in racemsonia, and echinocandins in Schizophyllum species other than Schizophyllum commune. So these are my references. Keep yourself abreast with all the information, and maybe by this year end we will be getting more approvals for the drugs in the pipeline. Thank you.